Good afternoon, everybody. I want to thank you for taking time out of your busy days to join us today to discuss the PIP QI reports. So welcome to the session. First of all, I'd just like to take a moment to acknowledge the traditional owners of the lands on which we're meeting today, to recognise their continuing connection to the land and waters and cultures, and pay my respects to their elders past, present and emerging. Just a moment of housekeeping before we get into the session. We have a bit of a time limited session today, so for that reason we will be keeping everybody muted. There won't be any opportunity to interact with your microphones, unfortunately, just because we don't quite have enough time to deal with that. But do please interact by the questions bar. You'll see a sidebar with a questions section. Feel free to write anything as it comes to you, even if it's not time for questions yet. We will save the questions to the end of the session, just also to keep time manageable. And if we don't manage to get through all of them, that's not a problem either. We'll assemble a bit of an FAQ document that we can answer all of those in a written format and send that out to you afterwards. Speaking of afterwards, there's also going to be an evaluation form in your inboxes that should be in your inbox today, either by the end of the session or by the end of the day. We would really appreciate your feedback, so if you could get them done and feed them back to us as quickly as possible. It will take you about 3 minutes to complete, so it's not a biggie. I think that's almost all from me. My colleague Madeline is behind the scenes helping as well, so she'll keep an eye on questions and alert me if there's anything that I've missed. As I said, they'll be left to the end, so I'll jump on again at that point and bring up questions with our guest speaker, Dr. Jeannie. So on to the PIP QI reports. First of all, a quick apology from us because we did say that the PIP QI reports would be coming out to you in July. However, we have really had to dot our I's and cross our T's, so to speak. We've done an extensive quality assurance process to make sure that they're extremely accurate before they come to you. So that's the reason for the delay. But I think that you will find these really, really useful in identifying potential gaps and opportunities that you can work to improve in your practice. If you have any questions or would like an in-depth discussion, reach out to your relationship manager. We're definitely here to help you, and we will be also making contact with you to see if you want to organise one of those. Now to introduce our speaker is Dr. Jeannie Knapp. She's a general practitioner from Richmond, and she's also the clinical advisor to our primary healthcare improvement team, which is the team that provides direct support to all of you. She enjoys all aspects of providing care to families and particular interest in health of children, chronic disease management and mental health problems. So over to Dr. Jeannie. Thank you.
Hello everyone, thanks very much for joining us today. As Juliet said, I'm a practicing GP owner, and I also work for the PHN. As you can see from my intro picture, I'm not from here originally. There's going to be a little mention of my friend in the picture in a minute. Juliet has already covered just some webinar etiquette, muting your mic, using the chat for questions, and we're going to have plenty of time for questions at the end. So before we get into the reports themselves, which hopefully you've all got in front of you, I'm really excited to share this innovation with you of the PIP QI reports. There's been a lot of work going on behind the scenes to bring them to us. But just before we get to the reports themselves, I want to set the scene a little bit about why data is important and why the reports are going to make data fun and easy to use. I'm a bit of a data geek. I love nothing better than a spreadsheet, and the PHN are collating this data for us and making it easy for us. I'm going to just very briefly, before we get to the reports, talk about why data is important. I'm going to talk just briefly about the quadruple aim, so what outcomes we're using our data to try and achieve. And I'm also going to just quickly refresh our minds, our memories about the PIP QI and the 10 measures, and then we'll get to the reports. So just quickly, why is data important? So a very famous primary care researcher by the name of Thomas Bodenheimer and his colleagues studied high-performing primary care practices and led them to a formulation of what's known as the 10 building blocks of high-performing primary care. And these building blocks describe the essential elements of that primary care that facilitate high performance. And in some ways, really can be extrapolated to running any business. These building blocks include 4 foundational elements. So the idea is that we have to have these 4 foundational elements in place before we can move on to the other ones. Number 1 is engaged leadership, and you saw a little photo of me earlier with someone who's widely regarded as being an excellent leader, and that's a foundational element of providing quality, and as is data. In my general practice, that data is going to be specific to healthcare, whereas if I was running a different sort of business, I'd still be using data to drive improvement. So hence data and using data is foundational to providing high quality care. As Peter Drucker says, if we can't measure it, we can't change it. And quality improvement is all about making changes. And if we can't measure it, we don't know if a change has resulted in an improvement. So hence having data as a starting point to that change and improvement. So having acknowledged that data is foundational to quality improvement, what is it we're trying to improve? What kind of outcomes does a high quality practice have or look like? So again, some clever researchers came up with what's known as the quadruple aim. High quality practices looked for improvements in all 4 areas. And those 4 areas are improved patient experience, improved provider experience, improved population health, and sustainable cost. And in our private practice environment, that might actually mean improved income. Primary care practices with a strong QI orientation continually seek to improve their own performance and the outcomes of their patients using the quadruple aim as a guide to the domains of improvement. So the Commonwealth have recognised the importance of moving towards more of a quality improvement framework by introducing the PIP QI. So I'm sure everyone knows that the PIP QI was introduced almost exactly a year ago in August 2019 to reward quality improvement in general practice, replacing some previous SIPs and PIPs. And it represented a real move to focus on QI rather than just service delivery. In partnership with your PHN, practices can choose any area of improvement informed by their clinical information system, i.e. data. However, the government have provided what they call the 10 measures as an eligible data set. You can use any measure, but these 10 measures are the measures that we're submitting to the PHN. And so we have focused on these 10 measures in the reports as a good place to start QI. So again, I'm just going to quickly run through what those 10 measures are. This eligible data set is submitted de-identified. It's based on active patients, so that's as defined by the RACGP, so that's having had 3 visits in 2 years. And it's based on previous reporting that Aboriginal Health Services had been doing to the Commonwealth for a number of years. All of the areas had clear clinical benefits, benefits and potential outcomes for our patients. Those of us receiving PIP QI are already submitting this data set. And as I said previously, you can qualify for the PIP QI using any data as long as you're doing it in partnership with the PHN. So quickly running through what those measures are. The first measure is the proportion of our patients, again, it's active patients with diabetes with a current HbA1c result, and that's within the past 12 months. Recorded smoking status, recording weight classification, then there's 3 relating to influenza immunisation. And this is in the past 12 months, those over 65 who've been immunised against influenza, those with diabetes, and those with COPD. Proportion, another recording one, patients with an alcohol consumption status recorded. And then measure 8 actually splits into 2. So kind of sneakily, there's actually 11 measures, because 8 is about recording those necessary risk factors to enable a cardiovascular disease risk assessment. So that's things like smoking status, blood pressure, lipid status, and that's split into for our Indigenous patients and our non-Indigenous patients. The proportion of our female patients with an up-to-date cervical screening, and the proportion of patients with diabetes with a blood pressure result. So let's get down to the nitty-gritty of the reports that have been developed using that data. So the data is submitted to PHN by a PenCat. As I've mentioned, it's de-identified, and it's focusing on those 10 measures and the demographics. And the PHN have consulted widely in producing these reports, including with GPAG, the General Practice Advisory Group, and practicing GPs, including myself, to try and make these reports as streamlined and practical as we can. What I'm gonna do now is a quick overview of the reports. And if you've got your report in front of you, feel free to go through the reports as I go through this report. The report I'm using is a dummy. It's made up of completely made up data. And I think there's one other practice online who are also using a dummy report. I'm going to do a quick overview of the 5 sections, then a more detailed look, and then we're going to do a bit of a drill down to some of the areas where this practice might make some improvements. So the first section is simply a reference page. It gives us a background of the reports, where we got the data from, reminding us the definition of an active patient, and then a little key to some of the symbols that we're going to see. So down here we've got a simple traffic light arrangement, a green arrow telling us that numbers have gone up, a red arrow gone down, and an orange one is neutral. I'll explain the trend lines later. So that's the first section of the report. The next section of the report is a lovely little one-pager that just gives us an overview of all of the QI measures for our practice. So here we've got the 10 measures. Down the left here, we have the 10 measures, or sneakily actually 11. And it just gives us a beautiful, quick overview. Our first column, it gives us the data from the last quarter. Our first column tells us that our percentage. So in this practice number 109, 71.16% of their patients in the last quarter had a current HbA1c result. And then a quick visual down the next column of how that compares to quarter 4. So for this practice, that number was slightly less than for quarter 4. And then a lovely little quick visual about how we benchmarked against the PHN as a whole. So on the right column is the PHN numbers, and so this practice was above average for those measures. In fact, they're above average for all those measures except for one of the QA8 measures and the 9, the cervical screening. So the next section of the report shows us our demographics. So again, this is this imaginary practice 109, and this is a breakdown of their demographics. It's based on active patients, and on there's 4 graphs. Top left, the gender breakdown of this practice. The next one on the top right is the breakdown by ethnicity. Bottom left is age by gender, and bottom right is age by ethnicity. Now this gives you a lovely instant snapshot of what's happening with the demographics of your practice. You might use that to understand your practice better. You might use it to think about an age group. I look at that little age group there of 5 to 14-year-olds and think, how am I, what services am I offering for that age group? Are we providing good access for that age group? So it just gives me a lovely quick snapshot of what my practice demographic is. The next section of the report is more of a drill down on each of those QI measures. So if we bring that up, each measure gets its own little breakdown. So again, we've already talked about the diabetes with HbA1c. So the first line tells us how many active patients with diabetes does this practice have. And we can see that there's the quarterly numbers there, and they're obviously a very growing practice because their numbers have gone up quite a lot over the last quarter. And when you get your report too, just a note that these quarters roll around, so you're always going to have 4 quarters of data to look at. Again, the little arrow tells us that the numbers in quarter 4 are up compared to quarter 3. And then the little trend line, if I can find the trend line here, my mouse is disappearing. There's the trend line there. The trend line gives us month by month, the red dot being the lowest month. And my interpretation of that little notch in the data is that for some reason this practice didn't submit data that month. The green dot tells us the highest number for the 12 months, and the little number next to it is an aggregate average. And the aggregate average for this practice has been sullied, if you like, by the months of not having data submitted. So each single QI measure is given its own kind of moment to shine in the sun. And then our final section of the report is the benchmarking against the PHN. So again, we have a bit more of a drill down by having some graphs for each measure that tell us some information about how this practice is performing against the PHN. The practice being the aqua blue dot, the PHN being the lovely orange brownie dot. And again, if we follow the aqua dot, we had the month where we didn't submit data, and then we're sitting quite consistently around that 72% mark, whereas the PHN sits around that 65% mark. So this practice against the PHN average is performing well with their HbA1c. Compare that to the cervical screening, and we can see that conversely, the practice is performing, again, ignore that notch where they didn't submit data, they're performing below the PHN average. There's been a bit of a pickup around here. They were sitting at 15 to 16%. They did something to get up to 20%, but they're sitting at around that 20%. So of eligible women, only 1 in 5 have been screened with a cervical screening test. There's a single page for each measure with some other drill down graphs. For this one, we have which group have had their age group have had their screening. So if I look at that, I can see it's the younger women who aren't being screened because there's only that many compared to that many, rather than the older woman. And we can also look at it by ethnicity. So that's the kind of overview of each section and a bit of a drill down into each one. But what I'm going to do now is think about how best practice might use this report to look at their data and make some changes. Now, just a word about benchmarking as we reflect on the data. Obviously, all practices are not created equally, and all practices have different challenges in terms of their demographics, their patients, their staff. And so benchmarking needs to be an individual thing that you think about what target you are aiming for. But 3 that you could consider looking at are how you're going against the PHN benchmark, how you're going against the RACGP benchmark, which is traditionally 75%, or against an ideal kind of blue sky benchmark of 100%. And I'm a pragmatic clinician, and I know that that's pretty rarely achievable. So hopefully with the magic of the interweb, you'll now see the full report. and just bear with me while I scroll to, so we've already looked at this page, sorry, my bad. We've already looked at this page. We know that this practice is doing really well against the PHN on all measures except for their Indigenous recording of cardiovascular risk factors and their female patients with cervical screening. I just want to have a bit of a drill down on two kind of things, this demographics page, and then we're going to drill down on one of the measures. So here's this demographics page, and when we are thinking about QI stuff, we often think in terms of quick wins, so simple, easy things that we can do that won't take much time or effort. We think about kind of medium-term wins, and we talk about longer-term wins. So looking at this practice's data, I can see one really obvious quick win, and that is this inadequately described or not stated gender. Here we have 222 people. Now they might all be female who are missing out on their invites for their cervical screening. Because the point I want to make there is that cleaning up data is not just cleaning data for the sake of it. We want to cleanse data and have it cleaned up in order to improve the quality of care that we can provide to our patients. So here's a quick win for this practice: 222 inadequately described or not stated. We could allocate someone to use PenCat to pull those 222, look through the file, maybe even look at their original registration form and correctly allocate them a gender, be that female, male, or other. A slightly longer term win for this practice would be looking at this inadequately described ethnicity. Again, not data just for the sake of data, but because of those 4,248 patients, we can assume that a reasonable number of them are Aboriginal and Torres Strait Islanders, and we might want to target that group. We've seen that the numbers for recording of risk factors for that group's not great, so we can only target them if we know who they are and we can identify them. So a much longer term project for this practice might be cleaning up that data. So just bear with me, I just want to flick through to the cervical screening one. Here we go. So we looked at this one before where we are underperforming compared to the PHN. So if this was my team, how am I going to use this report to try and improve this? Well, I think the first thing I'm going to do is I'm going to circulate the reports to the whole team. I'm going to get everyone discussing them, because this is what's obvious to me, but there might be something else hidden in there that another team member, maybe one of the receptionists, will see something that I don't see. So let's get the reports circulated. Let's get everyone discussing them. I'm also going to celebrate with the team what we're doing well. You know, talk about the things that, you know, that HbA1c number, they're fantastic. Hitting 70% is a really good result. And so celebrate those things and think about what are the things that we're doing to achieve that. What we can do it for HbA1c. How can we translate that to our cervical screening? We're going to use the reports to identify, so we're going to use that data to identify some priority areas for improvement. We've already talked about choosing some quick wins and then maybe some more long-term goals. And I'm going to, hopefully, this might be one of the things that my practice is going to work on. I'm going to try and set up a little quality improvement work group to try and prioritise quality improvement within my practice and to start brainstorming some ideas. So we can use what we call the model for improvement, which is essentially a framework for us to brainstorm some ideas. Sorry, back a step. Establish a goal, which for this will be improving my cervical screening rate. Brainstorm some ideas about how I might do that. Turn those into measures, and then using the PDSA framework, create little cycles of actions to try and put my ideas into practice. I'm always going to do an education session something as seemingly straightforward as cervical screening, getting everyone on the same page, making sure we're all thinking the same things, is going to just make any new initiative much easier to do. We might brush up on our pen cat skills. If I'm not using it, I might want to get my team to use top bar, because top bar will flag to me when someone comes in and they haven't had a cervical screening test. And so what are some kind of ideas that we might brainstorm around this particular issue? We might identify eligible women who haven't had a cervical screening test and maybe have an SMS campaign. Now, we wouldn't want to do that all at once because there might be thousands of them, but we could drip feed that over time. So that might be an idea that we could test, run through a PDSA cycle, sit back and evaluate and think about whether that's worked. Another idea we could test is that we could get reception to hand a little pink slip to women of eligible age with a message, something along the lines of, hey, did you know that 4 out of 5 women in our clinic haven't had an up-to-date cervical screening test? How about talking about this with your doctor today? So those are some of the things that we could brainstorm. So hopefully that's worked, and I've gone back to the main thing. We've got time for questions really soon, and we can go back to those reports and drill down more. But I just wanted to talk about how the PHN can help us on our QI journey. Well, hopefully everyone's got those reports in front of them. We can arrange a PIP QI virtual visit where your relationship manager can go through the reports with you. We're going to be running some drop-in Q&A sessions using resources like myself to ask questions about your report. The PHN has developed a QI toolkit, which is a really lovely, straightforward how-to for doing QI. We've also got the QI plans, which you can do with your relationship manager, and that doubles as documentation for your QI PIP. The PHN has developed a bunch of workbooks, including one specifically on the 10 measures, so you can work step by step through the workbook, helping you to improve those 10 measures. There's also one coming up for diabetes, and there's an upcoming IQI, so intensive quality improvement around diabetes. We've got our relationship managers that we can rely on. Of course, the PHN can train us in PenCat, it can install top bar, and we've also got the ever useful health pathways. Which brings me to the end of my spiel. And so I'm happy now to hand back to Juliet and start asking any questions or any comments from here.
Thank you, Jeannie. That was really interesting. Thanks so much for that. Just want to encourage you all to get putting any questions that you have into that question box. I have got a couple to start the ball rolling. Jeannie, what kind of documentation do you need to keep when you're doing quality improvement activities to meet the PIP QI?
Yeah, good question, Juliet. My understanding is that you just have to document it, but a really good structured way to do that would be to use the PHN's PIP QI plan, and you can work through that plan with your relationship manager. And not only will that help you to identify the goals that you might want to work through, but it will also act as documentation for the PIP QI.
Yep, that's great. I had a look at those. I'm in the intensive quality improvement arm, so it's I don't get to use those plans myself, but I had a look at those today, and they're actually really simple. It's just 3 dot points about what you want to achieve, and then I think 3 dot points about how the steps you're going to take. So really quite achievable. You could probably do it in half an hour. Just give some thought to it and then complete it, and then it sort of paves the way, if you like, for your next steps. So I think they're really useful for sure. I've got another question as well. If you are new to doing quality improvement activities in general practice, where would you start?
Look, that's such a great question, Juliet, and I think there's kind of no right or wrong place to start, but hopefully when I was drilling down on that process that our practice might do for their cervical screening numbers, just outline some of the places to start. Using your team is really important. The more you have your team bought into it, the more successful you're going to be. And using data, these reports are a fantastic place to start. Start somewhere. And I think one of the best pieces of advice I was given when I first started embarking on some QI work in my practice was start small. Try to you don't have to do the whole elephant. You can just take a little bite of the elephant. So I think those are some good places to start. Get your team involved. Use your data. Now you might use this wonderful report from the PHN, or there might be something that piques your interest that you're going to go and grab PenCat out and have a look at. And just start small. Just choose some small little bites. Work through the process and feed it back to your team. Use that team the whole way. But Juliet, you've got lots of QI experience yourself. Do you have any other top tips that you would also give a practice starting out?
Yeah, I was just thinking of jumping in there actually. Anyway, I just came out of a cancer screening intensive quality improvement project, and one thing that I really noticed was the teams that had a whole of team approach. So they didn't just involve their clinical staff, but they had their practice manager and also clerical staff involved. Really got a well-rounded perspective and came up with ideas that maybe just looking clinically we might not have seen. So I really want to encourage all of the practices that are listening, do think outside of the box and involve your whole team or involve members from your whole team, because you can get a really great perspective and some really great fresh ideas that way. So that's definitely something that I thought of. Yeah.
Yep. I think there's a couple of questions there,
yeah,
Julia.
that's right. I can see sort of flickering while I'm talking.
Yeah.
So I think I'll just scroll up a little bit because there's been a couple have come up. How can I engage our GPs into quality improvement activities in the practice? Very good question.
Look, I don't know that there's any. Well, I don't know that there's any one right or wrong answer. It's going to be about your GPs and what kind of sets them alight. What sets your GPs alight? And it's going to be different for every single GP. Some of them it's going to be about numbers. Some of them it's going to be about income. Some of them it's going to be about being part of the team. And I think you've just got to find the in for your doctor. Would you agree with that, Juliet?
Yeah, absolutely. Some love the data, some love competition. So
Yes,
sometimes
competition.
putting something up on a notice board and saying we're currently here, who's going to get to there fastest, or
we
who's
had a little league table for one of our QI projects. So we literally published a league table of who was the winner and and that really motivated some of the competitive ones at the bottom, really motivated them to change. So I think it's going to be about finding those motivators. And on that note, I saw another question come up there about getting people to enter data in the right place. And look, that's just such a challenge, because obviously the quality of the data in is only as good as the quality of the data in. And getting people to change is difficult, and getting people to change is difficult. But I think just starting the conversation and explaining why. I often find with my colleagues that if I just explain why, then that surprisingly often helps to just understand that we're not just doing this because it's fun to collect data, that it's actually going to improve patient outcomes by putting it in the right place.
Yeah, for sure. That's a very good point. Okay, we've had another couple flick through as well. Just go back. One person has asked who should be involved in quality improvement within the practice. I think we've sort of touched on that already. The whole team, ideally, or as many people as you can bring on board.
Yep, and in our practice, we have a quality improvement kind of working group, and we've also included a patient rep on that. Now, she doesn't come to every meeting; she comes to every third meeting, but she brings, she brings her kind of patient kind of voice to the team. But agree with you, Juliet, ideally you should have someone, the whole team, or at least a representative from all of your craft groups.
Yep, fantastic. Do you have any advice on what the PIP QI requirements will look like next year?
As far as I know, we haven't heard of any changes. It's just going to keep on as it is. All we're doing is submitting data and recording that we're working in partnership with the PN, and as far as PHN, and as far as I know, that's all we need to keep doing.
Yep, that's fair enough. Doctors are recording vitals in the notes and not in the right tabs. You probably spoke to that earlier. The last one I've got here, so if there are any more burning questions, please continue adding them. But the last one I've currently got is, what are the biggest mistakes practices tend to make when doing QI?
Oh, good question. And I think I'm gonna be a politician and not answer the question directly. I think one of the important things about mistakes is that we learn from our mistakes. And so don't see mistakes as a failure, but just see them as an opportunity to, well, what went well, what didn't go so well, what could we do differently next time? So applying that kind of lens to it. So I guess one mistake that practices make is worrying about mistakes and focusing on mistakes. We all make mistakes, we've just got to use them as a learning. I think I touched on one of them earlier, and that's about trying to take on too much rather than breaking it all down into some lovely small bites and just working away at that lovely little bite, getting that done. And I think probably the other one that comes to mind is being disconnected from the team, that it's just such an important thing that we're doing this as a team. Again, Juliet, you've probably got some other thoughts.
Yeah, well, definitely that's an observation of my last project as well, that practices that just had mainly the practice nurse and maybe the practice manager bearing the load together really did struggle compared to the practices that had a larger team that were all looking at how can we improve quality. And that's just a product of the fact that they've got a big workload and there's only two of them or one of them that are doing all that work. Getting that whole team involvement certainly helps. Another thing I think that is really important is measurement. A lot of teams have amazing ideas, but maybe haven't thought quite enough about how are they going to measure that. So at the end of the process, they go, hey, we improved stuff, but we don't really quite have a good handle on exactly how much we improved because we didn't measure properly at the baseline. Obviously, the PIP QI reports will help a lot there because some of the work's been done for you, but that's a big one. So having a bit of a plan about what we're going to do, but also what will we produce and how are we going to measure the outcome of it. I think that's a big one as well. I think we've got another moment in here. Just one more. Where can I access the guidelines for the measures? I want to make sure I'm up to date.
When you say I don't quite understand the question in terms of the guidelines for the measures, but the definition of the measures is in these reports, and I presume on the Health Department website, it's got the definitions of the measures. There's little kind of caveats for them, like, obviously the cervical screening one we just talked to is for eligible women, so women aged 25 to 70. That HbA1c was within the last 12 months. Most of the vaccination ones are within the last 12 months. But maybe if I haven't quite answered your question as intended, maybe just re-put the question into the DOFA thing.
Yeah, I'll just jump in there too. I was on the government page this morning. It is literally just health.gov.au and look up the PIP 10 measures, PIP QI 10 measures. Yes, this is the right page. It looked unfamiliar at the top, but there we go. The very first link that comes up when you Google PIP QI 10 measures is the health.gov.au web page. And as you scroll down, you get to a whole lot of fact sheets and guidelines and improvement measures and all sorts of resources there. And of course, that's the onus is on them to keep them up to date, so you can be fairly assured that they would be correct when you look them up. So that's what I would say there.
Are there any other questions there, Juliet? I saw one about are these reports, will these reports be expanded, or is this considered the final report? I presume the answer is that, like any project, we're going to apply a QI mindset, and we'll be reviewing the reports and reviewing feedback on the reports and continually improving them. But I don't think that there's any appetite to include other data other than the demographics and the PIP QI measures.
Yeah, and also another thought is that Health Pathways has got some information on the PIP QI as well, so, and also the RACGP, so definitely good places to be looking at for support there. There is one more question, and we're pretty much out of time, so this will be the final one, I would say. Can our relationship managers talk to our practice team on how to do the QI activities? Well, absolutely.
Absolutely, 100%.
Yeah, the best way to set them up and measure and plan. Yeah, that's
absolutely.
what we're here for.
Yeah, and there's another question I've just seen slip in there. Will this webinar be available, as we would be keen for other staff to view this? Absolutely, we're being recorded as we speak, and it will be available on the PHN website, Juliet?
Yeah, I believe so.
We'll let you know.
Send it out to all the attendees as well.
Yeah, we'll let you know. We'll let you know.
Yep. Oh yes, Jeannie also made mention of this earlier on, but I mention again about the PIP QI workbook that steps you through all of the different ways that you can investigate your gaps on each of the 10 measures, and gives ideas about ways you can, activities that you can do to improve those. So definitely a really good resource there. If you're looking at your report and going, oh, I reckon we've got a bit of work to do, that might be a really good place to start as well. So, yep. I think that's it.
I think that's it. Thank you, Juliet. And thank you, everyone, for
thank you.
Yeah, thank you, everyone, for tuning in today.
Goodbye, all. Thanks.